any longer would be really kind of, no pun intended, pushing the needle. If you exhaled heavily through the nose on that joke, don't forget to hit the subscribe button.
When do you want me to take off my pants?
Stop. That's for when the camera goes off. So you just stay. There we go.
I got some like soft girl hands.
Thank you, dude. I think. I don't know. You can see the callus on these hands. I'm a weightlifter, but hey, I actually do consider that a compliment, and I think that's kind of weird. Let me know if you guys think that's weird in the comments. I don't really know. As much as you can to my hands. Hey everyone, so today we've got an interesting patient case. We've got a guy who injured he tore his medial meniscus 7 years ago alongside his MCL, his medial collateral ligament. Basically, bad knee damage, and it was irreparable. However, he was able to rehab it with a lot of physio and has been doing pretty well since. 2 weeks ago, it flared back up on him, started getting really, really painful to the point of he was having issues doing his job. He couldn't work, he couldn't work out. So he's in today hoping to get a little bit of relief, get a second opinion on some of the rehab he's been doing, and hopefully he's going to be feeling a lot better by the end of it. And spoiler alert, he says he is. So great news there. Thanks for watching. If you guys can spare even 2 seconds, please don't forget to hit that subscribe button. Did you know that it's free? It's completely free to do that, and it helps me out a lot. But have great days, and as always, appreciate your support. RJ, good having you in today.
What's up?
Thanks for coming in. So RJ's got a really cool job. He takes business owners and makes them look way better than they actually probably are. But he's in today dealing with a knee issue, dealing with some back stuff. I'm going to let him walk us through it. So RJ, what's going on with you?
Yeah, so right now it's like just a reinflammation of my meniscus tear.
Okay.
Back in the day, like 2018, started off as tendonitis from like basketball, sports, and gym. And then I kept going at it because I'm like, oh, this doesn't hurt that much. And then tore my meniscus horizontally, so not repairable.
Yeah, that's not fun.
Tore my MCL, did a year or two of rehab slowly, and I was good from basically 21, 22 to like 2 weeks ago, which I woke up one day and I'm like, ow.
So you just woke up with it. Did you have like a particularly hard workout, or were you playing a sport the day before, or something obvious to irritate it, or not particularly?
Not particularly, but I guess stress over time, because I was in the past like month and a half I've been trying to like lose weight again properly, so I've been doing a lot more cardio.
Good on you.
In terms of like treadmill and then Stairmaster, which the first couple times I did Stairmaster, like it was really heavy on the knee, but I was like, it's not that bad.
Okay.
But doing that, lifting a bit heavier, and then just being on set or being working.
The combination effect really seemed like it. Okay. So we got a stressed right knee that's following some rather serious injuries from how long ago? 2018. So that's about 7 years ago now. Holy crap. Time flies when you're not paying attention. All right. You've also got some lower back stuff, and you said some upper back neck stuff. Can you kind of tell us about that too? Or? Yeah.
So this lower back started, I think, less than 6 months ago.
Okay.
One day I was just doing, I think, RDLs or barbell rows, and I just felt a tweak in my back, and ever since then it's been kind of weird. I'm gonna chalk it up to bad form, I guess, or something.
Could be.
And then it's always just been like very tight. I usually tell like the usual physio guy I see that like that scene in Incredibles where he gets pulled apart.
That's what you need.
That's what I need, but then he never really does it because it's not safe. But yeah, that's kind of where it is, and then I just always have tension in my neck and traps, just probably because being in front of the computer a lot.
So that, you know, Sarah, if you can actually include a GIF of them pulling apart, Bob? I think Bob is his actual name.
Right,
so people know what they're talking about.
Mr. Incredible.
Mr. Incredible, there you go. People know him by his alias. So that long axis distraction, we don't really know too much about it. It's a lot less studied as compared to just getting adjusted or cracked in the, I'm going to use the word normal way, but we can do that for your low back and everything today, no problem. So it sounds like where you need to work the neck, the upper back, the lower back, and especially find something to do with that knee. Now, rehab-wise, I know that you are seeing your physio. He's done some dry needling. I'm going to do some dry needling today. What kind of exercise does he have you doing for the knee? Like, I mean, you mentioned gym stuff, so my guess is you're a little bit more advanced than just the average person who is sedentary.
I haven't done anything at the moment because this past week and a half where it's actually been bad, I just rested and iced and just chilled.
Okay.
Starting this weekend into next week, I'm going to get back into working out and strengthening it. At home, right after I wake up, I do a little bit of like hip strengthening thing where I just like raise my leg like for a couple times.
A couple of leg lifts, okay.
Do that a couple of sets, but going into the gym, I was told to start with like wall sets, compound machine, quad, hip stuff, the abductor, adductor machines, as well as what else? Butt touches, squat wise.
Butt touches.
I don't know what the technical term is, but
touch is,
box squats.
Box squats. Okay, that I'm more familiar with than a butt touch.
Yeah.
Okay.
But like just go like a quarter of the way, or like how low I can physically go. And
Got
just,
it.
Like,
and then come back up from there. Yeah. Okay. So that all sounds very safe. I always like working with patients who have a background in kind of that weight training because they are able to get into more advanced rehab sooner rather than later.
Yeah.
I might check something later, but I'll get into that if necessary. So knee, lower back, neck, upper back, it all sounds pretty straightforward to me. We're going to get into the physical exam now, and then we're going to get into the treatment. Do you have any questions for me before we get started, or are we good to go?
When do you want me to take off my pants?
Stop. That's for when the camera goes off. All right, so RJ injured his right knee back in 2018, I think you said it was. And it's funny because I had forgot between the previous take and setting this up which one it was. And then he said, just look at it. And so there's a noticeable asymmetry in size looking at the right knee as compared to the left swelling wise. Has it always been like that, or is it really just these past 2 weeks that it's kind of gotten worse?
Past 2 weeks.
Just past 2 weeks.
After I like rehabbed it, it was still like maybe 10% bigger, but like
it was a lot closer.
Yeah, like the little bump here versus the indent here compared to this knee, like. As soon as I saw that, I'm like, okay, it shit's back.
Got it. Okay, so I'm gonna take this. First thing I'm gonna do is range of motion exam. I'm gonna bend that knee. Do you get pain with that, don't you? Okay.
Yeah.
Even just the flexion really on that side. So when we're looking at the inside of the knee, that's gonna be our vastus medialis. Okay, our quadricep muscle consists of 4 muscles. The VMO, the vastus medialis, is one of those. So if I do something, now keep in mind this might sting a little bit, but you just let me know if it's too much, okay?
Yeah.
If I find that it's actually there it is. I was having some trouble finding the joint line there because of the swelling. If I straighten out like that, is that particularly uncomfortable? Yeah, okay. I can see his face wincing there. Yeah, okay. What if we compare that to the other side? Now I'm pressing in the lateral joint space. Push that down. Nowhere near as bad as beforehand.
No, like the first time it wasn't bad either. It was just like, oh, I didn't expect that.
That doesn't feel good.
Yeah.
Okay, all right. Coming up, now we're into the vastus lateralis. Tender, but okay?
Yeah, just tension.
Just tension, okay. Now if I put the foot down here, I'm actually going to take a seat on this foot here. If I pull you like that, that's okay?
Yeah, it feels good.
It feels good, actually. You kind of like that pull-apart distraction. You probably would with the swelling there as a gap. What if I push it the other way?
Yeah.
That's okay?
Yeah.
Okay. Bring you up.
Also, hold on one second. I'm not sure if I'm lying properly, but there's something poking my head in
Slide down just a little bit. There you go. Okay. There's a metal piece there just to provide support. But some people's heads, if they got narrower heads, is that okay?
Yeah.
All right. And then...
Oh, yeah, that already feels weird.
This feels weird, huh?
Yeah.
Well, there is another man sitting between your legs, so how's this?
That's all right.
That's okay?
I think when you pulled it back to like sit inside, that's
okay. That's the part that was most uncomfortable for you. Okay, I'm gonna bend that knee, and I'm just gonna get myself up here one more time, poking through. How are we kind of center in the knee, poking in through there?
Nothing in this.
That's all okay, because that's the quadriceps tendon, which I believe you said was where the injury first kind of onset. Well, like you first had a tendinopathy, or remind me?
Patellar tendonitis.
Patellar tendonitis. Okay, that is patellar tendon is down low, guys. Quadricep tendon is up top. The fibers blend into each other, so they're essentially one and the same, just 2 different locations.
Yeah.
But you had that issue down here, and then the weakness predisposed to the injury there. Okay.
Yeah. Being in this position for like 20 seconds, there's like a lot of stress under the knee.
You feel like the support starts to really fire on from the hamstring.
Oh, yeah.
Like, okay,
yeah.
That's not fun either. Huh? All right.
Yeah.
We'll take a rest there. RJ was just mentioning that at his previous physio visit about 48 hours ago, 2 days ago, they didn't really work his lower back very much because they didn't want to have an impact on the hip, because if they had an impact on the hip, it'd have an impact on the knee. And that's very true, all right? Anytime you're affecting an area that is above, or an area, the areas below and above will also take effect. We're essentially one long chain, all right? That being said, it's been 48 hours. His pain's improved a little bit. I'm a chiro. I move lower backs without moving hips all the time. So we're going to tentatively see what we can do today with this. But you've got a lot of tension in the low back.
Yeah.
That's a lot of tension. That's the left side. You're saying you get pain on the right, yeah?
Pain on both sides, but the left is the main one.
Left is the okay. My bad.
Yeah, like just doing that already feels good.
That feels good for you when I press through. Right? It feels relieving. Okay, that's his SI joint, guys. The sacroiliac joint, bottom of the spine, connects into the sacrum, little triangular bone here, which then connects into the ilium or the hip bones proper. It's not actually your hip bone. Your hip joint's down here, but gapping and putting some pressure through that area. If that feels relieving, guess what we want to do? We want to adjust it. So we'll get there in a bit. Let's just do some osteopathic stuff first.
What does that mean?
Basically means I'm just going to try to mobilize the tissues with my own hands. Just try to move everything gently at first before I throw my entire body weight on you, right? Ooh, there's a spot.
Yeah. That's some good pain.
It's the best kind of pain. It's what we specialize in here. Here.
Yeah, similar type of pain, but not as bad as the left side.
Not as bad, eh? Okay, yeah. Good.
I guess in relation to hip and that, because my guy, he already knows, but my right leg for a little while, it naturally sits like this.
It's more rotated outward, eh?
Yeah, like right now it's fine, but like while I'm lying in bed or something, it just kind of goes like this.
Mm-hmm.
Which at first I was like, why? But then he's like, some people are just like that, so I kind of just...
Some people are just like that. So I kind of walk with a little bit of duck feet, with like my feet externally rotated as well. I'm going to slip back so the camera can see that. Externally rotated as well. It's related to the hips.
Yeah.
Okay, like the hips, if you have more external rotation available to you, your feet will point out that way. If you have more internal rotation available to you, your toes will come inward. Mm-hmm. So it's not something to be too concerned about.
Yeah.
Unless, of course, it's causing you serious grief. But, all right, so now how are we up in the entrepreneurial muscles? I call them that because we get a lot of tension up there.
Shouldn't be too bad.
Not too bad, eh?
Shouldn't be.
Good. Crushing big deals lately. Oh, look at that freebie. Okay, so we had a small incidental release there, but let's actually try to adjust this upper back here. Big breath in for me and all the way out. There's a good one. In. All the way out. There's another good one. Two little ones there. You can just breathe normally now. Yeah? Good. And you actually do feel okay in the traps. I gotta say, it's not too often that somebody gets off scot-free there, but you do feel okay there. Okay. Now I'm just gonna look at the knees real quick here. So there is some evidence swelling in the back of his. Oh wait, it was your. Sorry, what was? Well, I just gotta trust my eyes here. Of the right knee as compared to the left, same as looking at it from the front angle. When was the last time you had imaging taken of this knee, dude?
Years ago, because I didn't need to do it after it. I got rehabbed.
Okay, so that's comfortable. You can bend it, or that's okay.
For like there, if you want to keep going, I can tell you where. Stop.
Let's do that.
There's pain.
There's pain. Okay.
Yeah.
So one thing that I want you to be aware of here is, do you know what a Baker's cyst is? Have you ever heard of that before?
Yeah.
Yeah. Have you gotten imaged for a Baker's cyst before? Probably not, if you haven't had one in a while.
Yeah, nothing recent.
Nothing recent? Okay. Do you oftentimes get swelling in the back here when you get flare-ups of the knee?
I mean, this is the only time it's happened.
Only time it's happened, eh?
Yeah, in the last 4 years.
Okay. So a Baker's cyst, if you guys know what a disc herniation is, it's a very similar concept, except it's present in the knee, and you're more predisposed to it with your history of injury, I'm afraid, right? Mm-hmm. So with swelling in the back of the knee here and a limit on flexion, yes, the flexion is painful because of the meniscus, I'd want you to consider getting an ultrasound just to rule out that whether or not that's happened as well, okay? That's something you have to talk to your GP about, though. Unfortunately, we can't do those in Ontario. So typically when we're doing a lumbar adjustment, what we want to do is we actually want to bring the knee and the hip up in a flexion, but that's not going to be very comfortable on someone who can't get flexion past 90 degrees. So what we're going to do instead is I'm going to get you to scooch your hips a little bit closer to the edge here. Good. I promise you're not going to fall. I got you. A little bit closer. A little bit closer. Perfect. Okay. So I'm going to get you to actually bring the leg just forward like that.
Yeah.
And is that okay on the knee?
Yeah.
Good. All right. So from this position, you okay there?
Yeah.
Perfect. You guys probably heard that on the mic. The table also moved, but all right. Just the one little one. You can come back up for me. Perfect. And we're going to move the other. Did that hurt the hip at all when I did that? No? Perfect. And that's how you can adjust a low back without moving the hip. Bring this leg up. So this knee is fine. See this, because it's fine, we can actually just bring it way up in a flexion. No issues there with the adjustment. So from this position, get you up like this. Big breath in, all the way out. Breathe out, and I roll you towards me. Good. There we go. So definitely a lot more tension on the other side. It was a lot more challenging to get, but I'm happy this side's cooperating at a minimum there.
Yeah.
Ritual, do you get a lot of headaches or no?
I mean, from like work and people, but not from my body.
Are you positive of that?
Yeah.
Okay, I hope so, because as I poke through RJ's neck here, the very top of both, well, at least that left side, and also the right side, the suboccipital region is very tender to me, okay?
Yeah.
So usually that area is associated with cervicogenic headaches or headaches that come from the body, right? But I can imagine that dealing with certain individuals as well as running a stressful business could also exacerbate those things. A little bit of a chicken and egg. Do they exacerbate? Do they cause? Good question. If you retire, we can find out. Want to retire?
I don't got money to retire, bro.
Yeah, it's okay. Neither does anybody else in our generation. The willingness is there, but okay, yeah. All right, so to get that right side, very top, we're going to be doing a suboccipital movement. I'm going to get you to turn your head as far as you can. All right, you've had your neck adjusted before, yeah?
Yeah.
And you enjoyed it, didn't frighten you at all?
Yeah, I do it all the time.
Oh, okay, well that's reassuring. That's good, so you just stay. There we go. Very good.
Damn right, I got some like soft girl hands.
Thank you, dude. I think. I don't know. You can see the callus on these hands. I'm a weightlifter, but hey, at least I'm talented.
Yeah.
I actually do consider that a compliment, and I think that's kind of weird. Let me know if you guys think that's weird in the comments. I don't really know.
I'm trying to get you more engagement.
Soft, girly hands. Yeah. I guess it would, wouldn't it? Anyway. Let's check out this left side.
Oh, goddamn.
Drop, drop, drop. Good. Alright, and to get the left side, same concept. I want you to just relax the head as much as you can in my hands. Good job, man. So do you feel like you're able to get as high up as we just did yourself, or not particularly?
Like me cracking it?
Mm-hmm.
It depends.
Depends on the day?
Yeah.
Usually people struggle to release that very top segment themselves, but having the external force or someone else do it can be beneficial. Yeah, we still got quite a bit of tension in his neck here, so let's just give him a little bit of extra love.
How's my tightness compared to the rest of the people you usually do?
Honestly, you feel pretty par of the course in terms of you feel like you got more stress than perhaps you're letting on.
True.
But that's okay. We all have our stressors, right? Something tariffs.
We'll deal with that in a month.
Yeah, and then in another month. All right, let's check over here. Yeah, for those who don't get that joke, I'm based in Canada, and that's where we are. So don't forget to support your Canadian chiros on YouTube, also known as, I'm pretty sure, literally only me, by clicking the subscribe button. Thanks.
How big are you on YouTube?
We're at like 8.4 thousand.
Oh shit, that's really good.
Thank you. I'm my own biggest critic, though. I'm trying hard to get to 10,000 before the end of the year. So
yeah, as soon as you hit 10K, the rest is easy.
Well, that's what I'm hoping, right? But it's also just it helps with the ego of having another digit. You know?
No, like a bunch of my friends do YouTube, so
really,
I know.
I would love to meet some of them. Are they local?
Yeah.
Oh, well, I would really love to meet some of them.
It's all like filmmaking and content based though, so.
That's fine. Still like to meet them. Pick their brains. Get a coffee with them. Ooh, that's also fun.
Yeah. Is that a knot?
Yes. So that, as we get lower, we're getting into a different muscle group that I usually like to treat with the patient seated. So we're going to get into that after we work the knee, okay?
Yeah.
There you go.
Ooh, I was not expecting that.
You weren't expecting that, eh? Well,
Yeah.
I hope you didn't expect it, but like, it's nice. I
Yeah.
can't speak properly. Words are hard on a Friday afternoon. Anytime we are treating a knee, really like to include acupuncture as part of the treatment protocol. Now, the issue is that if we are uncomfortable in flexion, all right, or non-supported flexion rather, as we've set up quite a bit of a support here for his knee, we need to still make sure that the joint capsule is gapped or opened. And that's only really possible with flexion. But we managed to jerry-rig a contraption here for him. And we'll see if we're still able to get what we need to get here. So, you comfortable going forward with this there, RJ?
Yeah.
Perfect. Okay, so you just relax as best you can.
Yeah,
Okay.
the last time I did acupuncture, we put some electricity into it.
You did the electroacupuncture, right?
Yeah,
Okay.
both. And
I do electroacupuncture here. Did you like it?
the intensity was kind of a pain. Like, what I was going to say is, like, right near where, like, the pain is, like, here.
Yep.
He poked a needle there, and I made him move it because it was, like, actually fucking painful.
That's totally okay.
Yeah.
So what I'm going to say here is that if you need the needle out for whatever reason,
Yeah.
you just let me know when we take it out. It's that simple. Okay, you don't need to grin and bear it for the camera. You're the priority here. But we will do our first one right there. Nice. Okay. So as you guys might be able to see on camera, we are able to get that needle all the way in, which tells us that we comfortably were able to fit it into the medial meniscal joint space, which is exactly where he has his history of pain and injury, right? Let's see if we can do the same with the lateral aspect now, if we're so lucky. Well, is it luck or is it skill today, boys? Okay, let's breathe.
Felt that one.
Felt that one more than the medial, huh? All right.
Like, the first one I didn't feel at all.
Oof. We call that skill, not luck. Okay. So coming up, we're going to get into the VMO area now. Once again, that is the medial or the inside aspect of the quadriceps muscle group.
Felt that one too. That one's pinching.
Pinchy.
Yeah.
Once again, if it's too uncomfortable, usually I like to wait 30 seconds. And if after 30 seconds it's still bothering you, let me know.
Same.
We'll take it out, okay? Right, VLO.
Oh.
Ooh, that one gave me some resistance on insertion.
Yeah. That one's the worst one so far.
Well, honestly, I'm happier that it's the muscular insertions that are more uncomfortable on you than the joint ones, because the joint's where the history of the issue is, right? So that's good to know. Then lastly, we'll come on up on the quadriceps tendon here, arcing between the patella and the femur.
Ow.
Just like that.
Ooh.
Perfect. Okay, so here we go. We've got 5 needles inserted. And so you said you found the electroacupuncture a little bit too uncomfortable, eh?
Like, only in the one that was, like, on this side, so
Okay.
I had to turn it down, like, a lot.
All right. Well, let's just put it on lightly for you and see if it's bearable. If it's too much, we'll take it right off, okay?
Sure.
Okay.
How long do you have to go to school for all this stuff?
So Chiro, it's a doctorate, so it was an extra 4 years on top of my undergrad. So I was in formal schooling a grand total of 9 years because I did a double major and an undergrad thesis. But then I jokingly say I was in school for 10 years because my first year out in practice was more of a business internship than anything.
And so you're in school until like 28, 29?
Yeah, I graduated formally at 28. So 3-4 years ago? I can't even remember. Maybe it was 29.
Yeah.
All the time blurs together with COVID, right? I can't really recall a good chunk of it.
Yeah. My friend, he's my age. He's going back to school, and I'm just like, how are you going? Like, I like to learn in, like,
Well, what's he going to school for?
finance.
Okay, well.
I think he's trying to go for his master's or some shit, but I'm just like, I don't get the concept of, like, traditional education at all.
Of what?
Traditional education?
Yeah, as an entrepreneur, I understand that perspective, with exception if you're trying to get into a profession. I'm going to turn on the current here.
Yeah.
Okay, so we're going to start with the outside, or the white wire here, for the people who are watching. You let me know when you start to feel a little tingle, okay?
Yeah, I'm feeling it now.
Feel a little tingle, perfect. We're going to go a little bit more. Too intense, or it's okay?
Yeah, stay there if we're going to
Okay, we'll stay there for a bit. All right, now we're going to go ahead and do the other side. You let me know when you start to feel a tingle.
Yeah.
Perfect, okay. Now, something to note here for you guys, if you've seen me do electroacupuncture on the channel before, you're probably used to seeing a pulsation of the muscle that we're targeting. Here, we don't have the needles in two locations within the same muscle. So up here we're in the quadriceps. Down here we're in a joint space. The quadriceps doesn't overlap this joint space. It comes in, fuses the patella, and just avoids around it. That's why we're not seeing contraction here, and we're only feeling the sensation of the electricity, because you definitely feel something right now in the knee, right?
Mm-hmm.
Yeah. So just because we're not seeing anything doesn't mean it's not happening. Okay, it's still a live circuit going to play here. All right, so that was about 15 minutes. We're going to go ahead and pop him off this. Keep in mind that he did just have this done by his physio about 48 hours ago, so any longer would be really kind of, no pun intended, pushing the needle a little too far. So, if you exhaled heavily through the nose on that joke, don't forget to hit the subscribe button for more. Okay. All right. hooks are off. Time to take out the needles. Now, sometimes on removal, the needles can pinch a little bit, okay? Just so you're aware, please just keep that knee still, okay? 1, 2, 3, 4, and last but not least, 5. There we go. We are good. All right, so RJ's been seeing his physio for this knee for a while now, and it's great because he has a background in the gym, and he's also been shown the kind of foundational exercises for getting that quadriceps activation. Now, something that I find a lot of chiros and physios and exercise-based practitioners forget about is that the knee has a screw and lock mechanism to it, which is a fancy way of saying that it rotates, okay? It doesn't just swing forward and backward, it has a degree of rotation. So what I like to do in basics of rehab is I'll get you to take a ball such as this, and you're gonna put it between your knees, and you're gonna squeeze that, okay? Now, maintaining that squeeze, what I want you to do here is I want you to rotate your foot in and then out. Back out, good, just like that. So when we're doing this rotational movement, what we're doing is we're working a very small muscle in the back of the knee known as the popliteus muscle. And we'll put a diagram of it up kind of there so you guys can see. And this ensures that we target all of the directional influences or all of the directions possible by the knee to make sure we don't have a weak link in our rehab program. So again, the best thing you can do is to, yes, get back to the gym, but I want you to start incorporating this just as frequently as you've been doing the other quadricep-based movements, okay? Is that a little uncomfortable? It might feel like you're working it a little bit.
Yeah, like you're in the peak of the external, feel it here.
You're feeling it in the outside aspect, eh? Okay. Normal that that's the case, okay, especially with a newer movement like this, but I definitely want you to include this with your rehab program going forward, okay? I'm actually really impressed with my ability to maintain a squat like this for a prolonged period of time.
That was insane.
Practice, guys. Practice. Practice makes perfect. Okay. Now, recall when we were feeling through RJ's neck here, we did have more tension as we were getting, oh my god, look at this face, as we were getting lower down into the traps and the left scap area. So typically, y'all should be familiar with this if you've seen other videos on the channel. I like to do that with the patient seating. So I'm going to get you to look up and to the right to start for me. Perfect. I'm going to take an elbow. I'm going to put the elbow right here. And I'm going to get you to slowly look down into the left for me, RJ. Go ahead. Good. Awesome. And up to right. We're going to repeat that movement. Slowly down to left. Is this pretty intense?
Not yet.
Not yet? Okay, good. Up to right. Slowly down to left.
Oh, motherfucker.
Okay, it's pretty intense. You can tell. Good. Up to right. Down to left. If this is too much, what I need you to say is, my name is RJ and I'm soft. Okay?
No, that's good.
Then I'll back off.
I'm not a bitch.
Up to right. Exactly. I knew it. Good.
Oh, that's tight, yeah.
Yeah. That's why I like to use my elbow, not my thumbs. Good. Awesome. Okay. Face forward for me. Tilt your right ear to your right shoulder. Now slowly tilt your left ear to your left. Go ahead. Good. Right to right. Left to left. Right to right. Left to left. Woo.
Up.
Right to right. Left to left. And right to right. Left to left. Okay, well, we'll do that on the other side too. I want to beat you up much more than this.
Oh, that felt nice.
Good. Up and to left. It's like a therapeutic pain. Up and to left, good. And slowly down to right. Good. Up to left. Slowly down to right. Up to left. Slowly down to right. Left. Slowly down to right. And to adjust my own elbow there.
Nice.
Ooh. Up to left. Down to right. Good. Okay, now face forward for me. Tilt left ear to left shoulder. Now slowly right to right. Left to left.
Yeah, that's already tight.
Yeah, right to right. Left to left. Right to right. Left to left. Shrug your shoulders, shrug your traps up. Good. Yeah. Slowly lower them. Up. Lower. Feel like jelly?
Yeah, I usually do this one with my guy, but he doesn't shake me.
I'm a big shaker. Can I say? There you go. Good job, man. RJ.
Yep.
We just finished up with treatment today. We did work your knee quite a bit on top of what was already done to you. How are you feeling right now?
So far, so good.
So far, you're okay?
Yeah. We'll see how it goes like for the rest of the day and tomorrow, but yeah, I feel like relaxed and loose.
Okay, that's what we're going for, right? I do recommend you start incorporating that external rotation and internal rotation daily. How do you feel in the neck, the upper back, the lower back after what we were able to get in there?
Yeah, I feel... Honestly, can't tell right after, but in the moment, it was like, okay, yeah, relief and looseness.
Good.
It always takes a couple hours for me to be like, okay, like how does this like?
How am I feeling now?
Yeah, because that's what matters, right? So
you're not doing anything for the rest of the day. You're going home, you're taking it easy, but you're gonna start. Well, I mean, you have meetings too.
Yeah.
But you're gonna start incorporating the physical activity this weekend, or was it next week? You're gonna try to get back to it.
I'm gonna try for this weekend, depending on work, but yeah, in the next like couple of days for sure.
Okay, that's exactly what you would want to do. Okay. Yeah. The one piece of advice I give you might want to consider getting the ultrasound requisition if you find the knee doesn't start to improve, or if it gets in the way of your function for at least another maybe week or so.
Okay.
Then I would consider going to see your GP for that. The measure of success would be how far into flexion or how much can you bend your knee. If you can get it relatively equal to the other side, then we're okay.
Yeah. Right? Yeah, because that's kind of my thing too. Because before this happened, I was able to like stretch my quad properly when doing that, and now I'm just like I can't even do much.
Which is a sign of, again, that potential Baker's cyst that we talked about, but the way to confirm that is with imaging, right?
Yeah. So like, what's... I know you talk about Baker's cyst, but like, what is it specifically? Like, how do you like fix that?
So Baker's cysts, unfortunately, the only real fix for them is time. Okay, you can wait it out and it will go away. Some people like to get them aspirated, which is a fancy medical way of saying drained. High reoccurrence rate on those. It's sort of like flipping a coin, right? So it's up to you if you would want to go that route. Of course, I would say that you just give it time, because time will fix it, right?
Yeah.
But it gives us insight into why your functional scale would be a little bit less. It's like, oh, well, obviously you can't flex. He's got a big big sack of fluid in the way, right? So yeah, that would just help us confirm the actual diagnosis.
Okay, yeah, that does make sense. I do feel like there's a lot of fluid and just shit in the
There you go, exactly. Which is why me, as well as looking at the back of your knee, thinks like you should probably go get that imaged.
Yeah.
Any other questions for today? Anything else you want to talk about?
No, I'm all good.
No, awesome. Well, RJ, it was great having you in.
Yes, sir.
Thank you so much.
Don't forget to like, comment, share, and subscribe.
Thank you so much, RJ.